Good morning, good afternoon, good evening, and welcome to day two of the opening forum of the Align MNH Collective. My name is Aparajita Gogoi, and I'm coming to you from India. I'm really pleased to serve as your day two moderator on behalf of our steering committee. Today, we are going to do our absolute best to keep to our tight timeline. If we are running behind in our program, rest assured that you will not miss any sessions and we will communicate these delays and associated time changes to you. If you find yourself running virtually to sessions yesterday and you were late, have no fear. All of the sessions will be available on demand post forum. We will be active on social media throughout the proceedings and we welcome you to engage with your fellow attendees. Our forum hashtag is hashtag collective action MNH, and our MNH, Align MNH handles are at Align MNH. So talking about a bit about what happened yesterday, Queen Dubé, in her very powerful keynote address, challenged us to be bold in our approaches to accelerate progress in MNH. We heard from Tyres about the importance of using data, both quantitative and qualitative, to track progress. And we saw how the MNH exemplars and the WHO maternal health scoping review, how it used data to help identify key levers that have led to progress for MNH. We heard from Franca about the importance of investing in the health workforce, particularly in midwives. And we heard many countries echo this sentiment. Investing in midwives, in responsible task shifting and task sharing. And we also heard how in Guatemala, engaging traditional indigenous midwives who are still the backbone for MNH in rural communities, how important that is. We heard from Minister Tadise about the critical need for government leadership and accountability. And we heard how Sierra Leone used the very strong political will and commitment in the country, not just to prioritize MNH, but also to coordinate across sectors, align donors and partners around country-defined priorities. Our concurrent sessions yesterday further explored these issues, and we hope that it answered some of your questions around the state of evidence and programmatic experiences with respect to use of antenatal corticosteroids in improving the experience of care and reducing mistreatment of both mothers and newborns. And we hope that you picked up insights from the national forums for quality of care. For those of you who are joining us today for the first time, and as an important reminder to all of you who were with us yesterday, you will notice that we have simultaneous translation occurring from English to French. If you wish to hear the sessions in French, please click on the interpretation function on the bottom of each session. Note that if you select the French translation and if you hear English, please click on unmute and you will be able to hear French. In case you're having any technical difficulties at any time during the forum, please click on the tab above and someone will be there to assist you. In case you need more troubleshooting support, there are responses on the FAQ page. You will also see that the majority of our sessions have been pre-recorded. This was primarily done to avoid technical glitches, but also to ensure the equitable participation of each of our speakers who are currently in multiple time zones throughout the world. Please note the Q&A box, which is immediately to the right of your video player, and we encourage you to type any questions that you may have. It is important to us that there is time and space for all of you to ask questions. We will be responding to the questions both in the live Q&A portion of select segments as well as in the chat box. We plan to keep our speakers very busy, make them multitask, and they will seem to be in multiple places at the same time. And finally, we invite you to take advantage of the numerous networking opportunities, including private messaging among fellow attendees, as well as the option to attend several networking sessions after the closing today. With this, now let's get started. The reason we are not in person today and meeting virtually is because of the global pandemic that has upended and uprooted the world. And therefore, it is right, it is poignant that our opening plenary is going to focus on this particular issue and the impact that it has had. So, opening plenary is titled Resiliency in the Face of the Pandemic. It'll focus on government responses to maintaining and adapting MNH services during COVID-19. And it'll also include insights to mitigate future disruptions. And this session will be moderated by Dr. Miki Chopra, who is the Global Solutions Lead for Service Delivery at the World Bank. However, before I hand it over to Miki, I want to ask that we start a poll. You will see the link to the poll at the top of your video viewer, and it is also being typed into the chat box as well. We will first run the poll, and then I will have Miki share the results as part of the exciting panel that he would be moderating. With this, welcome again, and over to you, Miki.
Welcome to this plenary session on looking at the impacts and the resilience of MNH systems across the world in light of this COVID pandemic. As you know, the COVID pandemic has really stressed our systems. It's stressed the health care, hospital care, referral patterns, supply chains, and not to mention the huge impact it has had on the health workforce. And so I know many of you have been working on the front lines, have been engaging in the policy dialogues, really trying to manage the fallout from the COVID pandemic. And this is what this session is really about. We've got a top-notch panelists who've been at different levels of the system, thinking about, working with, and addressing the challenges of maintaining healthcare services, particularly for women and children. And so some of the issues we're going to tackle in this session include looking at the equity impacts, looking at the ways in which we're measuring the impact of COVID on maternal newborn health services, and most importantly as well, looking at hearing about some of the experiences of how we're coping and how countries are managing to mitigate and bring the resilience lens to this. And then finally, we'll look forward to what have we learned and how will we manage this better in the future as we build our new inclusive systems moving forward. So to tackle these really important issues and questions, we've got a really fantastic panelist, and I just want to quickly introduce you to them, and then I'll start with some questions, and then we'll finish with an interactive conversation, and then you'll have a chance to put questions to the panelists as well. So just starting with, we have Professor Hadiza Galadenche, who's the director of the Africa Center for Excellence in Population Health and Policy at the Bayero University in Kano in Nigeria. She's a professor of obstetrics and gynecology and the director of the World Bank supported Africa Center for Excellence in Population Health and Policy. She's also currently the vice chair of the National Reproductive Health Working Group and a fellow of the West African College of Surgeons and the Royal College of Obstetrics and Gynecology in the United Kingdom. And then we have Professor Priya Soma Pillay. She's the head of Department of Obstetrics and Gynecology at the Steve Biko Academic Hospital at the University of Pretoria. She is the head of Department of Obstetrics and Gynecology. And she also runs the University of Pretoria Research Center for Maternal, Fetal, Newborn and Child Healthcare. In addition, she serves as the president of the College of Obstetrics and Gynecologists for South Africa and as the honorary secretary of the South African Society of Obstetrics and Gynecologists and a member of the FIGO Executive Board. We also then have Ms. Pauline Oringo. She's the Advocacy and Policy Country Lead for PATH. She's in Kenya. She has over 2 decades experience engaging with governments in the Africa region, advocating for development and implementation of stronger policies and investments in women and children's health and global health research and development. She's also one of the 3 civil society representatives on the Global Finance Facility for Women and Children's Adolescents Investors Group. And she's also part of the senior group in PMNCH as well. And last but not least, we have Dr. Gagan Gupta, who is a maternal newborn health specialist at UNICEF in New York, although he's shortly on his way to Nigeria for a temporary assignment there. He's a neonatologist and pediatrician by training and led the UNICEF health programs in the state of Madhya Pradesh for 6 years, as well as then leading subsequently the UNICEF team in India in newborn and child health from 2013 and 2019. And he has a huge amount of experience and the front lines as well. So a fantastic panelist, and I'm going to get started straight away. And I'm going to start with you, Gagan. In your role with UNICEF, I know you've been actively monitoring how COVID has impacted health systems across the world with data on coverage, drops and disruption of essential M&H services during the pandemic. What's the most revealing data that you have recently analyzed, and what does that mean for prioritizing M&H services moving forward? But maybe focus first on the revealing data that you have so far.
Thank you, Mickey, and greetings to all of you from UNICEF headquarters. Over the next 5 minutes, I will try to give you some of the glimpses from what we have seen in terms of the secondary impact of COVID-19. Now, with 4 full quarters of pandemic-induced disruption and 2.9 million deaths, 2 things have stood out very clearly. First is the fragility of the routine data systems, and second is the reluctance to share data, both by countries and often between the partners. This 1 year also saw transitioning from models to qualitative surveys and now quantitative data. When we started, we had a good tailwind learning from Ebola, and we were able to send the message very clearly and early to countries that please also try to monitor the maternal newborn child health services, protect, preserve, and track them. What we also did was we tried to look at the data from 48 countries and see what it brings in terms of the program narrative. We tried to look at both low and low middle income and upper middle income group countries across all 7 regions of UNICEF, and tried to look at tracer indicators for community, outreach, and facility services. For facility, we took institutional delivery and C-section rates. For outreach, we took antenatal care and immunization. And for community, we took postnatal care, pneumonia, and diarrhea. Now, there are 3 or 4 major macro trends which we have seen at the end of Q4. The first and foremost is there is a differential impact on services delivered through different service delivery platforms. Immunization services were hit early and hard, but were also the first to recover. So the services which were being delivered through like outreach, like immunization, and other community health services, they were hit early, but they also recovered faster. For the facility-based care, the impact has been much prolonged with a slow recovery. And also, for most of the facility services like institutional delivery, C-section, care of the small and sick newborn, the risk is immediate. There is no catch-up which you can do, unlike immunization. And another important thing is pneumonia, diarrhea, and childhood consultations have shown a strong beating across the board, across all countries, and across all the data which is coming from different partners. The second important thing we realized was it's not only about coverage. There are countries where coverage has not been impacted, but we also need to look at the quality. And quality of care has taken some suffering in some of the countries, whether it's HIV testing during antenatal care, the stillbirths, asphyxia deaths, the whole issues of commodities and human resources. The third important message is there has been a varied impact across not only services, but also across regions and countries. What we have seen till now is South Asia and Latin America have been severely impacted with more uniform disruption. Severe both in terms of countries being affected and to the magnitude they have been affected for the services. While Sub-Saharan Africa is affected, but the impact is more patchy. Not all services are affected and not all countries are affected. You have countries like Nigeria, you have countries like Angola, you have countries like Zimbabwe, which have taken strong impact. But then you also have bigger countries like DRC, Ethiopia, Ghana, which have not shown much impact over these quarters. And this also points to the fact that we need to relook at the current straitjacketed modeling approach, taking these variations into account. And lastly, we also saw very strong linkage with the COVID caseload, how the system responded to COVID and the mitigation measures. And here is the importance of looking at subnational data, because at times you may find that not much has happened at national level, but when you look at the provinces which are really affected, you find the disruption has happened. And in the next couple of minutes, I will just take you through two patterns of recovery, one in South Asia and one in Sub-Saharan Africa. Now, this is one of the big countries of South Asia. It's basically Bangladesh data set. And if you look at the data for all the 3 quarters in Bangladesh, across the whole continuum of antenatal care, institution delivery, the postnatal visits, immunization, diarrhea, and pneumonia, you will see 2 things. One is that the disruption has been pretty strong and severe. And except immunization, which has recovered very fast, in Q2, there was a 20% above the previous year's baseline. The other services continue to show a very slow level of recovery. And this is seen in many other countries of South Asia, where across life course, all the services got impacted. They also had a high COVID caseload. They also had more stronger lockdowns. But now also about immunization, in spite of what you see as a recovery, still 180,000 children missed Penta 3 because the dip in Q2 was much more severe than the recovery which happened in the subsequent quarters. Now, when we move to the next country in Sub-Saharan Africa, and that's Kenya, if you see the difference, here, the antenatal care, institution delivery, and C-section, this segment is largely spared, but there's a strong impact on pneumonia, diarrhea, and other childhood illnesses. And this is important for Sub-Saharan Africa because here, the post-neonatal mortality still remains a major cause. And this kind of trend you will see in other African countries as well, where impact is more around immunization, pneumonia, and diarrhea, while institutional deliveries and C-sections have comparatively been less affected to the extent what we saw in South Asia or in Latin America. And this is the last point I wanted to make. Like in the previous slide, you saw that Kenya did not show much impact on the institution delivery. But when you look at the data of Kenya in terms of counties, the 2 most important adjoining counties which were there, which are the capital region and the adjoining county, they had actually taken a strong decline in terms of the institutional care. So it's also important to look at the subnational data if the national data is masking your inequities. And that's what I would like to make it as a first point. Thank you.
Thank you, Gagan. That was really interesting and fascinating. I'm sure it'll give rise to many questions afterwards. But I do want to move on because we do have some more in-depth information and data to share with you. And I'm going to turn to Hadiza. You've been doing a lot of work in 3 of my favorite countries, Bangladesh, Nigeria, and South Africa. What were some of your revealing findings from those settings?
Thank you very much, Mickey, and good morning, good evening to all participants. I'm presenting a paper that we recently published just last month on the effect of COVID-19 on maternal, newborn, and child health services in Bangladesh, Nigeria, and South Africa, a call for a contextualized pandemic response in LMICs. Now, I'm presenting this on behalf of my other co-authors. And really, we looked at, the Bangladesh Health Management Information System. We looked at 2 tertiary health facilities in Nigeria and 2 tertiary health facilities in South Africa. And we looked exactly at the services they provide in terms of antenatal, immunization, as well as delivery services and family planning. Now, just as Gag has said, there will be recurrence of more pandemics, and in fact, we now have, we have countries that are already in the third. We now have countries that are in the third phase of the pandemic. Now, the COVID mitigation plans should be integrated with the standard care provision so that we can enhance system resilience, so that we can cope with all other health needs beyond just COVID. And we have to have a contextualized mitigation plan because not all jackets, not all jackets fits all. So we've got to contextualize our own mitigation plan, especially for the LMICs. And we're using Bangladesh, South Africa, Nigeria as exemplars. Now, just as the last speaker said, in Bangladesh, there was evidence of reduction in the antenatal care attendance, in the family planning attendance, as well as vaccination of children. And we have up to 56% reduction in the month of April. In Nigeria, we had up to 100% reduction in our attendance in antenatal care in a particular hospital. In South Africa, we had between 5% to 28% of reduction in antenatal. And in terms of family planning clinics, they were all reduced up to 100%. In vaccination, we had up to 50% reduction in vaccination. Now, looking at normal deliveries, there was evidence of reduced numbers of normal deliveries and cesarean section. If we have an increase, for example, in Nigeria, we actually noticed that it's actually because we had many emergencies, especially eclampsia. We had many more patients coming with eclampsia in the months of the COVID pandemic compared to other months. Now, the blanket coronavirus pandemic response is likely to undermine the progress towards country-defined SDG targets and cause additional public health crisis, especially in the LMICs. We looked at, the policies that these countries had in place, the guidelines that were produced, the preventive measures that were taken, the lockdown measures, and looked at it holistically. And at the end of the day, we said, if you have to avoid, this additional public health crisis, then you must have innovative strategies in LMIC's context. We should prioritize maintaining existing health priorities, especially maternal newborn child health, while responding to the challenges of the COVID-19 pandemic by adopting a holistic approach. Now, the suggested measures we put in that paper were: one, we must involve the local MNCH care providers and managers. Government should not just decide on, the guidelines and the policy. The healthcare providers must be consulted so that we can understand the breadth and the socioeconomic impact of this COVID-19 and the COVID-19 response and their relationship to maternal newborn child health provision. We should also have plans to segregate the different tiers of the health system. We have the primary healthcare, we have the secondary, we have the tertiary. Instead of just having one holistic strategy, we must segregate it based on whether we're providing primary healthcare, secondary healthcare, or tertiary healthcare. And then also, we must have an efficient and robust communication or combination of community-based education. The community has to be really educated on COVID-19 and the need for continuation of MNCH services, as well as training of even the healthcare workers. Then we should have appropriate tax shifting policy in place. We should limit duplication of services and efforts, and also avoid wastages of resources. And then lastly, the COVID-19 mitigation strategies should be integrated and embedded within the existing HMIS of the respective countries. This is important so that we can generate evidence-based policy decisions to inform resource allocation and tracking of MNCH and other non-COVID-19 services, as well as COVID-19 services. So in conclusion, we said that we must consider the political, economic, and contextual factors when we're thinking of a resilient health system. Not just the health system, but other things are important. And there must be coordination between all the actors, and there must be good communication and information sharing and reporting channels. And then there must be the communities and the health professionals have to be fully involved and taken along so that they can help inform locally designed approaches. And then we must have further research is required in these low middle income countries so that we can have culturally relevant and context appropriate approaches. And then of course, we must ensure that we maintain essential health services in spite of any pandemic that we have. Thank you very much.
Thank you, Adiza. I think that was a fascinating presentation and answer, really bringing out the heterogeneity of the impacts it's having, even within the same country, but also your clear messages about the need for locally relevant and contextual specific responses. And that brings me to the third panelist, which is Pauline. So I know at the request of WHO and the support of the Bill and Melinda Gates Foundation, PATH has been tasked with tracking government responses, but also the work that you lead, which is to engage with policymakers about how to strengthen the MNCH services. So I was wondering if you could just share some of your early experiences about that, your engagement with policymakers. What have been some of the challenges and successes that you've come across in translating policies into action or understanding the data better? And so can you just share some of those with us, please, Pauline?
Thank you, Mickey. I think you ask a really fundamental question about what did we observe, how have we worked with policymakers. I just want to walk you through some of the work that PATH has done over the last few months, and we hope to continue this as we get deeper and deeper into the pandemic and the changes happen. PATH as an NGO works in over 70 countries, and one of the things that we became aware around March and April of 2020 was that different teams within our organization were working to support national governments in development of policies that could help the countries respond to COVID-19. And for me, being based in Kenya, I was working very closely with the government to support that process of the government figuring how do we pivot our policies so that they could respond to the needs within the country. So what this led us to was with support and collaboration, including funding from the Bill and Melinda Gates Foundation, we did a catalog and synthesize government policies on the maintenance of essential health services during COVID-19. We solicited policies from local MOH, from technical partners, global partners, and implementing partners. And finally, we were able to analyze 198 policies across 115 essential health services in a range of countries. So we did cover 119 countdown countries, but we did very specific deep dive into 5 countries, and I'll talk about what those countries are. What we were looking at is we coded these policies so that we could see what were the governments doing with the policies. 3 things we observed: that there were recommendations around adopting the delivery of essential health services to ensure continued provision. Just about almost 60% of countries had policies, or rather 60% of the policies that we looked at had that recommendation. We also observed policies recommending continuing of policies, but with specific infection prevention control measures in place. About 58% of the policies did make recommendations around that. And there was a third one where we observed pausing or suspending of essential health services, and that was only in 11 of those policies. But what did this lead us to is that even we had some nuances. Even when there were adaptations or where there were recommendations for suspension, it was not entirety of policies of services largely. Many places it was very specific to how those were suspended, or so it wasn't entirety, because governments, we observed, did strive to make sure that services work in keeping despite the challenges that they were facing. So from this work, we did a taxonomy of services service delivery adaptations. There were quite a number, whether you're looking at appointment scheduling, because governments were working to ensure that there is no congestion in their health facilities, they're spacing out people. There was also integration at point of care. We observed that telehealth consultations was a really key one. And when I speak later about an example from my own country, I'll speak about that. There was prioritization of high-risk patients around MNH. We'll look at how that happened. Multi-month prescribing, especially where patients could go for a few months without necessarily having to see a physician or attend a health facility. Recommendations for alternative treatment. Extended service hours was another key observation. Task shifting, and I think my predecessors, I think Hadiza spoke about this issue of task shifting. Self-care by patients. There was intensified outreach in some cases where things had been different. Commodity delivery, presumptive treatment, patient intake reconfiguration, and of course, home-based care. And then there were specific designated COVID facilities and planning for lost progress. Let me just go into one of the countries. We worked in Burkina Faso. We looked at policies in Ethiopia, India, Nigeria, and Kenya and Pakistan to look at to be able to do deep dives. So among these deep dives, I'll only share very quickly what we observed in Kenya. And this is specifically adapting health service delivery at point of care. So for maternal newborn health, policies recommended that antenatal care visits for pregnant women should be reduced to 4 face-to-face visits where feasible. For patients who are at higher risk, they could go in, but for an average patient who is not facing any risks, they could do only about 4, but also supplemented by 4 teleconsultations or virtual contacts, whether they were being called by phone or they would get a short message or whichever form of virtual contact that they could have with the health service providers. In terms of task shifting, guidance on postnatal care, encouraging dividing patients among different risk levels. For women who had low risk, the recommendation was that they should be attended at the lower levels of care, whether they're looking at level 2 or at the level 3, which is a health center level, so that then their travel is shorter and also they can spend a shorter amount of time within the health facilities. For appointment rescheduling or scheduling, we saw staggered appointment scheduling was noted for multiple health services, primarily for appointments for routine immunization services and contraception counseling. And I'll say for a very specific note, contraception counseling, where possible, patients could be, this is where telemedicine also did work. Sometimes patients could be called, counseled, advised, and then they could be advised on how they could easily and quickly pick up their prescriptions. In terms of recouping lost progress, policies recommended that providers enumerate cohorts of children who may have missed their vaccine doses and develop an action plan for catch-up vaccination. I'll just share in agreement with what Gagan said, that child health services took a very specific dive in Kenya. Immunization was really hard hit, especially the first 3 to 4 months, but there's been a rebound upwards for immunization services. Just as treatment for sick child also did take a big hit, but that's also on the rebound. So let me just share up to that point, and I'll look forward to further conversation.
Thank you, Pauline. Really interesting. Let's now jump back to a little bit more of a deeper dive, because there are some subtleties when you look at the data, and this is something that Priya, I know you've been thinking about and brought out when you've looked at your data. So could you just share with us some of the insights that you've gained in South Africa when you've particularly been looking across urban and rural areas and the particular patterns of utilization and changes?
Thank you, Mickey. I'll be looking at the effect of COVID-19 on the use of maternal and reproductive services and maternal deaths in South Africa. I'm going to start by giving you a slight overview of our maternal mortality rates over the last decade and a half. So the National Committee for the Confidential Inquiry into Maternal Deaths in South Africa has documented a rise and fall in maternal deaths, with us reaching a peak of institutional maternal mortality ratio in 2009. And this was at the height of our HIV epidemic. And with a nice downward trend to 2019, when our institutional maternal mortality ratio was recorded as below 100 per 100,000 live births. In the following slides, I'm going to look at the usage of maternity services, and I'm going to be looking at births in facilities, initiation of antenatal care, contraceptives use, and termination of pregnancy services. And we'll be comparing 2019 to 2020. So if we look at births in facilities, we see that there's been an increase in births in facilities in 2020 compared to 2019, but the increase was less in Q2 and Q3. And we saw a sharp decline in April, and that was the start of the hard lockdown in South Africa. And then there was another dip in July, and that was the peak of our first wave. If we look at the births in our facilities, we saw that the increase in facilities was particularly in the rural provinces of Limpopo and Mpumalanga, and those are the two red circled areas, with a decrease in births in the province of KwaZulu-Natal, and we think that women chose to deliver at home in these provinces, and also in our metros, a significant increase in the metro of Islanzeni, which is in Mpumalanga province. If we look at our antenatal care, overall there's been a slight increase in antenatal care visits, but we see a sharp decline in April and in July, and this corresponds to the start of our hard lockdown in April, and in July to the height of our first wave. Again, this slide looks at our antenatal care first attendance, and we see a significant increase in antenatal care visits in rural areas of Limpopo and Mpumalanga and in the metro of Islanzeni, but a decrease in antenatal visits in our urban provinces of Gauteng, Free State, and the Western Cape. So we see an increase in antenatal care and first visits in rural problems, but the metropolitan areas had a marked decrease in the first antenatal visit. Contraceptive use declined significantly in 2020 compared to 2019, and this remained low all through Q1, 2, and 3. Similarly, our termination of pregnancy services was lower in 2020 compared to 2019. In terms of maternal mortality, if we look at the first quarter, and if we look at 2019 compared to 2020, we see that for January to March 2019, there were 270 maternal deaths, and this decreased to 235, there was a decrease to 235 in the first quarter of 2020. And this translated to a 13% decrease in maternal mortality for the first quarter of 2020 compared to 2019. And this followed the downward trend that South Africa has observed over the last decade. But what happened in Q2 and Q3? This was the start of our hard lockdown and the COVID pandemic. We had an increase in maternal deaths from April to September 2020 compared to 2019, with a difference of 132. And this translates to a 30% increase in maternal mortality for the second and third quarters of 2020 compared to 2019. Thank you. I'll stop there and we'll go on to further conversation later.
Thanks, Priya. Very sobering statistics, but also showing the power and the value of really digging into the data, both to bring out some of the key messages around excess mortality, but also these patterns which make for very distinctive policy recommendations, which otherwise we would not be aware of. And I'm going to come, that's what I want to explore now with the panel in a little bit more detail, which is really the so what. So Gagan, coming to you first, you know, what's been fascinating about what you've been doing and with the data and looking at it at a global level is how much more informed we are this time around than we were with say, Ebola even. But what are some of the lessons that you've learned in terms of how do we use this data for giving key messages to policymakers and what to do with the data?
Thanks, Mickey. And as we take stock at the end of Q4, what we see is that immunization services are largely coming back to track, with very few countries now, with reduced levels of immunization at the end of Q4. For institution delivery, the impact is going to spill over to Q1 of 2021. And for pneumonia and diarrhea, there needs to be a lot of country deep dive to understand what is the exact reason behind this. Because we are seeing it across all reports, the WHO surveillance data, the qualitative data and the quantitative data. Is it social distancing and better hand hygiene? Is it reduced reporting? Or is it people not taking the children to the health facility? Or is it a mix of all? But that deep dive needs to be at the national and subnational level. So the first message is countries need to prepare for varied level of interruption and recovery for the next couple of years. They have faced the worst of COVID. Probably these waves will come which will cause disruptions, but not to the extent which has happened in the first couple of quarters. The second important thing is immunization program has got some key learnings for the maternal newborn health program as well. If you see, the recovery of immunization was guided by 4 or 5 factors. The first was the restoration of the global supply chain of vaccines, because in Q2, the global supply chain took a dip, and UNICEF supply division data says that after Q3, the supplies were restored back to normal. The second was resumption of outreach immunization sessions. A lot of immunization disruption was because many countries stopped outreach immunization, and the resumption of those sessions was the second major factor in immunization recovery. The third important factor for immunization was enhanced outreach activities, catch-up kind of things. And though for institution delivery and C-section you cannot do this, but for antenatal care, continuity and postnatal care, still some ground can be recovered. And lastly, the strong use of data and communication by immunization program. Across all 48 countries, getting immunization data was much more easier as compared to getting the MNH data. And probably MNH community needs to learn from the immunization data systems and the way the immunization also integrated the community engagement part much better, and the messaging to the community is much better. And lastly, as we move into 2021, the physical access to care is improving with localized lockdowns, not very extensive lockdowns, but the financial barriers will hold the key, both for providing the service by the government and for receiving the service by the families, as more and more families face financial hardships moving to 2021.
Brilliant. Thanks, Gagan. Some very clear lessons learned and messages there, and I think that'll be very useful for us to bear in mind as we move forward. Adisa, I know you've been at the forefront of helping the Nigeria system, and particularly the places that you work, to understand how the epidemic is impacting on maternal newborn health and services. Do you want to just give us a little bit more of the flavor of both what you've been doing in Nigeria, but also perhaps from your collaborations across the countries as well?
Okay, thank you very much. As I stated earlier, each country has to really look at its political, economic, social, a system to be able to really plan, the strategies to mitigate the effects of COVID. So in Nigeria, it was very important that, at the beginning of the COVID, when we had the real peak of the pandemic, we needed to have guidelines and policies in place. These guidelines were not available, especially in the tertiary system, in the tertiary healthcare system. And that is why I said it's important to look at the tertiary, the secondary, primary, because what we will adopt in a tertiary healthcare system would definitely not be the same in the primary healthcare level. So we were able to have guidelines that we could use in the tertiary health system. And then of course, a national tax team, which also had a state tax team that gives, guidelines and policies for the different states and for the different local government. What is important that looking at guidelines and policies, then you need to adapt it to your own situation. The issue of tax shifting was very important because then a lot of the work that could be done initially only by doctors were now being done by midwives and community health extension workers, because we have a tax team policy in Nigeria. Then of course we had huge challenge in provision of protective equipment, and we had to have a lot of philanthropists and NGOs and people coming to the aid of the health system. Various strategy, and in fact we tried the tele system. You see, you can only do that in the urban system, in the urban region. You can't do that in the rural areas. And we had mobile community extension workers for our family planning products. But what is required is that all the major stakeholders together, that we don't have to do it again when something happens again. We have a standard plan that we need to follow. That's we require it to work. Thank you, Mickey.
Thank you, Adiza. You clearly brought out the importance of guidelines and policies, and ideally having them even before the outbreaks happen, but also how can we learn from each other? And I was interested to hear about your task shifting guidelines as well. Maybe we can explore that in the Q&A later. But that does bring me to Pauline, and very great to see that PATH has taken leadership in this in terms of the tool that you've developed and the tracker as well. Can you give us any more detail? I mean, the Kenya example was very interesting, of how countries have used the tool to make changes, to learn from each other, and what adaptations you're making to the tracker itself as well.
Thank you so much, Mickey. I think following on what Hadiza said, first, let me speak about how have we shared this tool. We've disseminated it quite widely through a network of partners, including WHO, who have also pushed it to their focal points so that it can be, people know about it, people can use it. But I must say, the point at which we haven't been tracking on country implementation. Maybe that's the future we should be looking towards, or the response, so that we have very specific examples of what's happening with the dashboard. It's a gap that we have, but we would also be happy to hear from colleagues, from participants and the panel, what else needs to be done in terms of how countries can adapt this tool and utilize it to improve their service delivery and the response and maintenance of essential health services. I think just speaking to some of the points raised is the issue of learning across countries. What we observed, countries were reconfiguring their services or adapting their guidelines and policies a little differently. And because of that, there is a real opportunities for countries to use the tracker to look at what have others done and how can they learn and borrow that into their own situations. For example, where services like ANC have been recommended reduced number of visits, but also combine that with follow-ups, either through phone or through virtual platforms, or through community health volunteers or community health workers. Those are some of the lessons that could be borrowed across countries and strengthen that peer learning. I think the other thing that is an adaptation is the countries do need to be able to publicize their policies and guidelines, even to their own publics, so that then there's availability, people know what they can do and cannot do, and also to figure out how do they reach the farthest points of provision of services. And finally, I would say another adaptation is underlining the need for data. If you look at where there are places where you found, like we say, data not found, that is really a pointer that there's something that needs to happen in terms of improving data systems so that then there is better tracking. So I think those are some of the adaptations. But going forward, I think in terms of speaking to what have we done in terms of adapting the tracker itself. This tracker isn't what you see now, isn't what it was at the beginning. It's evolved over time. We initially focused on the global map, and then we heard from stakeholders there was desire to compare countries, to look at specific documents, and that led to the addition of the dashboard creation. Similarly, now there are visual stories that do the brief overviews of adaptations, and those arose from the questions that the stakeholders from different places and countries and institutions raised. So in short, I would say this process has been very interactive, also very iterative, and I think the dashboard will continue to be updated as we continue to learn and hear and interact with our country colleagues. Thank you.
Thank you, Pauline. Priya, this brings me to you because really interesting that this finding of the shift to rural areas, which could have huge implications for the response, not just in South Africa, but in other countries. So I was just wondering, would you want to share some reflections of how this has impacted on your thinking and the approach in South Africa? And indeed, if you have any further data, I mean, I was you know, it was terrible to see the extra deaths which are happening. Do you have any sense of where they've happened? Have they happened in the rural areas more than the urban? But anyway, just in general, your thoughts on this rural-urban issue.
Thank you, Mickey. We've observed two markedly different effects of COVID-19 on maternal care. Although majority of the infections occurred in the urban, densely populated areas, we saw a migration of women from urban to rural areas, with rural provinces experiencing pressure on services due to women migrating from the metros back to their homes. And this created an increased burden on already under-resourced areas. So rural areas had to cope with a lot more non-COVID maternity care compared to what they were previously accustomed to. The metros, on the other hand, with a significant increase in infections, were inundated with severe COVID-19 specific conditions, resulting in difficulty in managing routine emergencies. So we saw not only increase in deaths due to COVID, but also increase in non-COVID related deaths in our urban areas. So I would say that in preparation for future responses and pandemics, our response will need to be targeted at solving the problems in these, or tackling these difficult issues. Thank you.
I think it's been brilliant. Thanks, everyone. I really enjoyed listening, and there is some clear messages that are coming across. Great. Priya, I think you've sort of put us to a point now where, you know, I know South Africa, you're hoping that it won't happen, but we are starting to see some uptick now in the number of cases again. So there is another wave coming. So maybe starting with you this time, can you give us a short response? What are the key messages you're giving to the Ministry of Health or to the Minister or to the Director about how to better prepare now for the next wave as it comes and hits South Africa, for example?
I think in South Africa, it's important that basic maternal and reproductive services remain open, and women should be informed that they should still attend antenatal care, contraceptive and termination of pregnancy services. It's important that adequate transport is available to facilities, but also between healthcare facilities. There should be adequate PPE for both pregnant women and healthcare workers. And then healthcare workers should be given emotional support during these difficult times. Thank you.
Yeah, that's great. That's great. I mean, does anybody else have anything further they would like to add on top of that? Pauline, in terms of advocacy, are there key things that you want to say around advocacy?
Yes, Mickey. Thank you so much. I think a very big takeaway from all this, from the sprint analysis, is that as governments do adaptations and as ministries work to adapt their policies and guidelines, it's important that they don't widen the existing inequalities. You know, when you think about very strong recommendations around telehealth and telemedicine, that must be coupled with the realization that there are inequalities around digital access, digital literacy between populations. Even if they live in cities, you'll find people who have access and others who don't. Also, the level of literacy is different. The network coverages are different. So if you're targeting countries that have wide coverage, that has to be thought through, and then some different solutions have to be tailor-made for different regions. And I think the other final thing I want to say is that, particularly for those in the advocacy space, it's important for them to work with governments to take the guidelines as far as they can. It's sort of very common in African settings. My country specifically, you have policies that people at the lowest levels of care and communities are not aware of, so they don't get very well implemented. And COVID has provided an opportunity for dissemination of guidelines and walking people through guidelines. We did this in Kenya through virtual platforms, including having civil society provide a feedback loop back to the Ministry of Health. I think those are lessons that need to be incorporated as countries move forward, because for us here, we are already in the third wave, and that's a reality we are facing, and it will be the reality for many different countries. Thank you.
Fantastic, Pauline. I think equity is a key issue. Thanks for raising that again. Hadiza, what about from the research perspective? Any thoughts on, what for you is the priority research, that question or issues that you would like to put on the table moving forward?
Yeah, so thank you, Miki. I think it's very important that we conduct research in the various countries, LMICs and high-income countries, to really answer the questions that are related, which means if we're in Nigeria, we try to answer the questions that we're really struggling to answer, to be able to put up these strategies, these policies, these guidelines. Just as Pauline said, telemedicine, yes, you can have it in the urban areas, but you can have it in rural areas. You're going to continue to increase inequalities. So we must do research to answer so many questions. There's so many questions now. And another question that I think the neonatal maternal research community should answer is whether there is really a relationship between some of the maternal conditions like eclampsia and COVID-19, because for us in Nigeria, we saw a huge increase, statistically significant increase of eclampsia, and compared to other months and other years, compared to the COVID-19 months. So there might be a relationship that we're still studying, because it's an evolving disease. COVID-19 is an evolving disease, so we must study that. And of course, with the advent of vaccine, pregnant women are not given vaccines now, and children. So there must be more research to really find out, the efficacy, the safety, and so on of the vaccination of our women. Because at the end of the day, if other people are vaccinated and our pregnant women are not, then we're going to be having problems of either transmission. We might even have a transmission, we don't know, of the in utero transmission and so on. So there are a lot of questions, and I think research will answer that. And then, of course, the data and the evidence at the end of the day should help us inform, policy decisions and the directions of the way forward.
Terrific. So just to remind everyone, please do start typing your questions in and comments, because we are going to move to Q&A. So Gagan, just before we do that, let me just turn to you for your sort of thoughts around one key message or one key action point that you're going to be prioritizing to help countries prepare for the next wave.
Thanks, Mickey. Moving forward, one of the key things would be to invest in strong data systems and build the national capacity to monitor their own data. We have seen in countries like Bangladesh, Nigeria, Uganda, and Kenya, very good national monitoring during the COVID, with a government-led partner-supported monitoring mechanism. And every health manager should be able to narrate the story of his or her district And every health worker should tell what's happening in his or her village so that they can take corrective actions immediately. Second important thing would be to now look at the mortality, the impact on mortality. From many countries in Q2 and especially in Q3, we started seeing increase in the maternal deaths, increase in the stillbirths, and increase in the neonatal deaths. So I think the UN IGMI group will have a huge task, in 2021 to see what actually happened on the ground in terms of mortality. And lastly, we will need to protect the financial resources, given the fact that there will be a huge pressure because of the COVID vaccine, which is also equally important. But the fiscal space needs to be identified either with domestic resources or pooled partner funding, and high impact intervention should be prioritized, bringing it more closer to community so that the access can be much better. Thank you.
Well, good morning, good evening, good afternoon, colleagues. Thanks for joining us today. We're going to have now move into our question and answer session. But before we do that, we're just going to share with you the poll results. So if you can just pull up the poll results on the question regarding whether equity has worsened or improved. It's quite a clear response there. Thank you for everyone for responding. But obviously there are great concerns regarding worsening of inequities. And so that's a very clear message. And that's something I want to start with. And I'll start with you, Priya, because I know you've been looking at this quite closely in terms of the differential impact. And we did have a couple of questions. One from Susan regarding cesarean sections and whether those rates have changed. But also I know, and we've seen already, that you've been following closely the rural-urban changes and shifts. So I just wanted to hand it over to you to just give us some further reflections on the equity issues that you're seeing in South Africa in particular.
South Africa, we've seen, like I've said previously, a significant movement of women from urban to rural areas. Traditionally, our rural areas are less resourced in terms of allocation and resources given for healthcare. All our tertiary hospitals are in the main rural areas, and with the movement of women, these rural hospitals and rural clinics were not given additional resources. So I think it's important to see that with pandemics like COVID, we should expect women to move back home, and we should look at reallocation of resources so that there is some equity. In terms of the cesarean section rates, I can give you some data from South Africa on the COVID-19 hospital admissions of women. And women who were hospitalized for COVID-19 and then delivered either during the COVID-19 infection period or post the infection, we observed a 62% cesarean section rate among these women. The main indications for cesarean section were maternal medical conditions, and this was during the active infection, mainly due to respiratory distress and respiratory morbidity from the mother. We also saw some cases of or increased rates of fetal distress, and cesarean. That was the second reason for our increased, or second reason for our cesarean section reasons. And then also we saw an increase in hypertensive disorders in pregnancy, and cesarean sections related to preeclampsia and eclampsia. Thank you, Mickey.
Thanks, Priya. That was very clear. I know, Pauline, you're having some challenges. Just want to check, are you, what have we got you right now? Yes, we have. Great. Hi, Pauline. Once we have you, Joy did put a question around how do we better use routine data? And so could you just comment on the use of routine data in your charting of progress and the toolkits that you mentioned? Can you hear me? All right, we'll skip Pauline.
I hope you can hear me.
Yes, we can.
Thank you so much. Let me speak quickly about use of routine data. I think one of the observations we made, especially here when we looked at the data in Kenya, the routine data has become a strong basis for decisions and also for informing the policy changes that we observed. Some of the things like looking at, access to services utilization, some of the service, things like noting things like child health services going down, those were noted generally out of routine data. So that has underlined the value of routine data. That said, because of the challenges of staffing, sometimes the routine data needs more to be done. But overall, our takeaway from the work we did is that routine data and improving routine data systems is critical for health systems to function within COVID, and even as we continue to push for continuity of essential health services. Over.
Thank you, Pauline. You were very clear. And so just to remind participants, there is a tracking tool that Path and others are doing. So we will give you the link for that as well. Gagan, I want to turn to you because John was asking about some of the insights, further insights that we can get from this data, such as the ones we saw from Priya in South Africa about rural urban and the difference in cesarean sections and so forth. Any further reflections from your side, particularly around quality? How can we use the data, or do you have examples of where we're using data to also get a handle on whether quality is deteriorating or not?
Right. Thanks, Mickey, and for a very pertinent question. It's important not to only look at coverage, because at many countries we are finding that coverage is fine, but still the quality has gone down, which is reflected in increase in the stillbirths, increase in the asphyxia deaths, or the reduction in the HIV coverage with antenatal care. If a good antenatal care is there, it has to also have HIV testing. You also have to have early initiation of breastfeeding with skill attendance at birth. So in many countries, what we are seeing is that some of these proxy indicators of quality have shown a dip, though the coverage has not declined. The second thing is also there are many efforts of tracking commodities. We have the global data from the vaccine supply chain from our headquarters, which has shown that in quarter 2, there was a decline in the global supply chain. We also have data about supply division data on ORS zinc requirements from the countries, and we found that South Asia had this time massive reduction in terms of ORS zinc procurement from supply division. It might have also happened that they must have procured it through local sources, and that needs to be followed over a period of time. So all in all, it's important to look at the commodities, to look at the human resource deployment, and some of those efforts are already there, like GFF in Nigeria, in their facility survey of 200 plus facilities, showed that 37% facilities had lack of oxytocin. Same way, the H6 survey in the Isaro region showed that 30 to 40% facilities did not have Maxsulf, misoprostol, oxytocin, and vaccines. These were the most important commodities that were running in short supply in SRO region in 15 countries. So there are efforts. What is important is to bring everything together as a program narrative so that we can guide the program managers that they need to look at multiple data points to come with what is actually happening at the national and subnational level in each of their countries. Thank you.
Thank you, Gagan. That's very sobering to bring that to our attention. And Hadija, this does talk to another question that was posed about the safety. Tradep posed a question around, what's happening with PPEs and crowded facilities. What's your impression from what you're seeing in Nigeria with regards to health worker safety? Because we know many health workers have died and have contracted a COVID infection.
Okay, thank you, Mickey. As you said at the beginning of the pandemic, we had a lot of challenges regarding, patient safety because we didn't have enough PPEs. And we had a lot of patients a lot of healthcare workers getting infected and, in fact, some dying. And some, in fact, not, having challenges in trying to provide care because some of them stopped coming to the health facilities. But then the government, mobilized a lot of funds and started bringing PPEs. We had philanthropists bringing PPEs. We have international organizations supplying PPEs. But there was another challenge because we needed to train healthcare workers to know how to PPEs. So now we had to start doing a lot of training. And with the training, there was social distances and challenge of bringing people together. So there were a lot of challenges, but I think we've learned, and that is what about COVID-19. Now we've learned, and I'm sure we have stock of PPEs now, that at least with more pandemics now of different waves, now we are now being able to actually address the issue. So governments will have to provide PPEs to the health system, and there must be training, because if you use a PPE and you're not well trained, you end up infecting yourself. And a lot of education, because you need to educate the healthcare workers to assure them, of their safety. And I think that is important, especially female healthcare workers. A lot of the healthcare workers were female, and then you now have to go back home to the family. So really a lot of challenges, and with people having mental problems, and therefore you need psychological support. So a lot of learnings actually from COVID-19.
And finally, Priya, Francis does make a great suggestion about, we have examples of trying to reduce the workload by integrating services or being more creative. Do you have any examples from South Africa or elsewhere that you want to just share on that?
Yes, Mickey. In South Africa, healthcare was brought together, and people from other disciplines had to assist physicians and family physicians had to assist family physicians with COVID care. We also had to open up hospital beds and try and reduce non-emergency services. So the biggest interventions that had to be put in place was the stopping of elective surgery, and only emergency surgery and emergency patients were seen at the height of the pandemic. During the hard lockdown and up to level 3 of our lockdown, the government also banned alcohol sales. And this contributed significantly to reducing the number of emergency cases that we saw in our emergency units, particularly trauma and assault cases were reduced, and this assisted in creating capacity in our hospitals for the management of COVID cases. In terms of outpatients, we were allowed to then extend hospital or chronic medications for our non-emergency cases and patients who are stable. So we had to think about interventions to free up hospital beds, and the ban on alcohol and the stopping of elective surgery cases contributed significantly.
Thank you. We've run out of time, so thank you to the panelists. I hope you all enjoyed this 1 hour with us. Really important insights in terms of what's happening, very sobering, but hopefully as a community we can raise the awareness of these issues and try and get back on track the progress that we've lost. So thank you to the panelists, and Apajita, I hand back to you.
Thank you, Mickey, and esteemed panelists. That was at the same time a fascinating but very sobering discussion on the impact of COVID-19 on maternal health and newborn health. Lots to learn from the various strategies that you all shared, which was used for prioritizing services in order to keep MNH high on the agenda post-pandemic. As Khadija alluded to, not all jackets fit well. So we really got to contextualize our own mitigation plans depending on where our own countries are at any point in time. And I think the most important takeaway for me was the message that how countries need to prepare now. They need to prepare now for recovery of services over the next couple of years. And in order to do this, we need to prioritize ongoing research. We need to push for investment in strong data systems and support countries to monitor their own data and to protect financial resources for preserving and recovering access to care. So thank you so much, Mickey and speakers. We will now very quickly transition to our concurrent technical sessions. Please visit the agenda tab and select the concurrent session that you would like to be part of. You can select from 3 sessions. The first one is focus on establishing inpatient care for small and sick newborns. The second one is on maternal and perinatal death surveillance and response, which will talk about implementation at the country level. And the third session is on stillbirth data and parent voices. It'll no doubt be a tough choice, but like yesterday, rest assured that a full recording of each of the session will be available for viewing on demand post the forum. As we transition into the concurrent session rooms, we bring to you another selection of videos from the White Ribbon Alliance and PMNCH. It'll begin rolling in a few minutes. And I also wanted to share with you that all these videos, including the wonderful video screened yesterday from White Ribbon and PMNCH, which featured community voices, all of this will be available for post-forum viewing via our partners pages on the Align MNH website. After the concurrent session, I look forward to having you join back in the main plenary room, in the virtual plenary room, as we close out day 2. Thank you.